Hi, welcome everyone to our tobacco cessation webinar series. My name is Olivia Duffy. I'm a health educator for the C.A.T.C.H program at Argus Community, which means Community Action to Combat HIV and Hepatitis C. What my role is that I am like I said before, I'm a health educator. So I conduct sexual health group and confidential sessions, not only sexual health, but I also do mental health and tobacco cessation and COVID-19. Um, and since August, we've been doing this webinar series on tobacco cessation every Tuesday at 2 p.m. and every Tuesday at 6 p.m. So today we are going to talk about tobacco use and behavioral health conditions. Next slide, please, Sean. So what I mean by behavioral health conditions, I do mean specifically substance use disorder. The purpose of this webinar is to bring awareness to the effects of tobacco use on people who are using substances and who are, in this specific community. Next slide, please. So I'm just going to throw up a few defining terms here. A lot of use, what I talked about substance use disorder, I used specifically use, not necessarily abuse or dependence. And even sometimes addiction could also be thrown in there as well. And people sometimes use them interchangeably, but, when talking about alcohol and drugs, but they don't really necessarily are interchangeable. So with use, substance use, it means any consumption of alcohol or drugs. So that can be as very common as, just having a beer with friends or during dinner, having a glass of wine. That's considered substance use. It may not be a problem, or it may not lead to any type of abuse or any type of dependency in some people. Substance abuse, is when someone continues to use drugs or alcohol use even when it causes problems, such as trouble with work, family, or their health. So this is when you're continuously using drugs or alcohol, because alcohol is a drug. You use it knowing you'll be fired if you fail a drug test. That's a sign of abuse. So like if you could fail a drug test, that's considered drug abuse. And drug dependence or substance dependence it's usually an addiction to alcohol or drugs, and won't be able to function without it. You're unable to stop drinking or stop using specific substances, and you have a physical withdrawal symptoms when you try to quit. So these are the differences in use, abuse, and dependence. Abuse tends to have a bit more of a stigmatizing connotation behind it, so we don't really recommend using it because of, abuse does lead to a very triggering type of reaction from a lot of people. Next slide, please. And even though I just defined those particular terms for you, it could still be really difficult to distinguish between them, even, with just the regular use, abuse, and dependence. So substance use disorder is what it can intertwine with drug addiction. So drug addiction is a disease that affects a person's brain and behavior and leads to an inability to control the use of a legal or illegal drug or medication. So substances, this includes nicotine, alcohol, marijuana. These are also considered drugs. So this considers a substance use disorder. So if you're someone who is addicted or has a big dependence on substances, you may continue using the drug despite the harm it causes. So the American Psychiatric Association has actually updated their criteria for talking about addiction, and they do use the term, like I mentioned, for substance use disorder because of a lot of the stigma that does go around drug addiction. And that term, it's very stigmatizing to people. It actually turns away people from getting the help that they need. So that's why they kind of go more towards using substance use disorder. Now, someone with a substance use disorder, this includes these following signs and symptoms: using substances in larger amounts for longer than intended, making efforts to stop, but unable to actually do so, spending more time getting, using, and recovering from using that substance, having specific cravings and urges to use that substance, continuing to use the substance even though it causes social and relationship problems, giving up important social, work, and recreational activities because of the specific substance, taking increased risks related to the substance, continuing to use the substance when the user is aware it causes psychological or physical problems, needing more of the substance to get the same effect, developing withdrawal symptoms when stopping the substance. So yes, these are some of the signs. I do know they do talk a lot about like addictive personalities and people who have addictive disorders. Um, that could also, I know a lot of people do throw that in with a substance use disorder. If you do have an addictive personality, you have addictive disorder, that does not necessarily mean you will have a substance use disorder in your past. Addictive can mean a lot of things. It's not always related to drugs and alcohol. It can mean other specific highs you get from doing specific things such as shopping or relationship wise, one specific person. So just also throw that out there as well. That's why drug addiction seems a little too stigmatizing for a lot of people. So if you are going to use someone to describe someone as someone who is using consecutively substances, you would use substance use disorder. Next slide, please. Okay. So, substance use in the United States. So, according to the National Survey on Drug Use and Health, so NSDUH, about 19.7 million American adults, so this is actually including people 12 and older, have battled a substance use disorder. And that was as recent as 2017. Almost about 74% of adults suffering from a substance use disorder in 2017 struggled with an alcohol use disorder. So of the 19.7 million, 74 of that was including adults suffering from alcohol use over other drugs like cocaine, marijuana, and nicotine. So alcohol is very damaging. What we've noticed, especially with a lot, alcohol is is seen as probably the most common form of a substance use disorder. It's very easily accessible for a lot of people, and it's socially acceptable to be drinking out in public. Whereas for a lot of drugs, such as coke, uh, marijuana, they're not really seen as the same. So they're easily accessible, and unfortunately, a lot of people do suffer from heavy levels of alcohol use. About 38% of adults in 2017 have battled an illicit drug use disorder. That same year, 1 out of every 8 adults struggled with both alcohol and drug use simultaneously. In 2017, 8.5 million American adults suffered from both a mental health disorder and a substance use disorder or co-occurring disorders. They do tend to go hand in hand. Substances can alter our brains a little bit. We do become dependent on a lot of substances. And, a lot of people did use substances as in order to cope with a lot of mental health issues. So it is very common for someone who has a substance use disorder to also have some type of mental health issue or a mental health disorder. Any type of drug abuse or addiction can actually cost the American society more than $740 billion annually in lost workplace productivity, healthcare expenses, and crime-related costs, which is just a simple fact that I want to put out there. And it also, like I said, shows a lot of stigmatizing relations, workplace productivity, a lot of, prejudice against people who do use alcohol or substances. It does take a toll on them as well financially. And, people are arrested for, carrying substances or under the influence. So obviously that the money racks up. Next slide, please. Tobacco use and quitting among individuals with behavioral health conditions. So any adults with mental health or substance use disorders. So that's where what I talked about, behavioral health conditions. So that's what it correlates with. Adults with that smoke cigarettes more than adults without these disorders. Mental disorders are conditions that affect a person's thinking, feeling, mood, or behavior. This could also be, depression, anxiety, bipolar disorder, schizophrenia, and many others. Substance use disorders occur when frequent or repeated use of alcohol, drugs, or both causes significant impairment, such as health problems, disability, and failure to meet major responsibilities at work, school, or home. And approximately 1 in 4 adults in the United States have some form of behavioral health condition, like I mentioned before. And these adults consume almost 40% of all cigarettes smoked by adults, which is a lot. um, Research has found that cigarette smoking increases the likelihood of relapse among people in recovery from substance use disorder, which I found very interesting because they always kind of portray a lot of people who are in rehabilitation facilities. A lot of them are kind of encouraged to smoke. So they have some type of coping mechanism to get their mind off of the urge to use any type of substances. But from the research, it finds out they're actually more likely to go back and relapse. But so there are research that suggests that helping patients quit and remain abstinent from smoking may improve their chances for sustained recovery from use of other drugs. Next slide, please. So this is tobacco use prevalence among persons with mental health disorders. So about 34.6% of adults with any mental illness reported current use of tobacco in 2016, compared to the 23.3% of adults with no mental illness. So individuals who are, like I mentioned before, about anxiety, depression, schizophrenia, bipolar disorder, any individual who has a mood disorder, psychosis, anxiety disorders, development disorders, and substance use disorders are more likely to be addicted to nicotine than those without these disorders. And, we have mentioned previously in our past slides and webinars, nicotine is really the one that is very challenging part of quitting smoking. There's such a big dependence on nicotine, especially. We've noticed it with even these e-cigarettes that don't even have tobacco in them. People are getting addicted to Juuls and the Blue brand and hookahs. They're all addicted to the specific nicotine. It's not just tobacco, and that does take a detrimental turn on you. It does do a lot of damage just having nicotine itself. It does a lot of damage into your lungs. It impairs your lung function as well, all of your respiratory issues. And what we've also mentioned in the time of COVID, nicotine and smoking in general, regardless if it is tobacco, any type of nicotine product, marijuana, it actually weakens your immune system. So that means you are actually more likely to get a higher case of COVID or any other infectious disease, any type of airborne disease, because of the smoking aspect. So I thought I'd also mention that as well. And nicotine, like I said, in general, is a very challenging dependence, but it is particularly challenging for individuals who are suffering from, schizophrenia or any type of psychiatric disorder. And it's actually, smoking is higher in individuals who are schizophrenic. It's about at least 90% of individuals who are diagnosed with schizophrenia smoke cigarettes. So it's very interesting to note that. Next slide, please. So this is just a graph of current use of any tobacco products among individuals with any mental illness compared to adults with no mental illness. So you see here, any tobacco products, it is 34.6%. That's what I stated before. And there's the 23.3 with individuals who do not have a mental illness. Cigarettes, there really isn't that much of a jump because cigarettes is the most popular tobacco product in the United States. So it just shows a lot. So it's 30.5 compared to individuals who are non-smoke, who do smoke but do not have a mental illness. It's 18.4. Cigars is 6.2 for individuals with any mental illness. Those who do not have a mental illness, it's 4.5. And smokeless tobacco, smokeless tobacco for individuals who have a mental illness, it's 3.4. And for smokeless tobacco for adults without a mental illness or are not diagnosed, it's 3.5. Yeah, so very interesting. In 2016, there was a very big case in 43.5 of adults who smoke cigarettes actually reported binge drinking in the past month compared to 21.7 of adults who don't smoke. And it's been very consistent in those numbers as well. So I thought I'd mention that as well. Next slide, I actually talked about that, but that's just the picture I want to show. That is very they kind of correlate, like I mentioned before, and it's very common. That's what I think also people need to realize, and it's kind of just swept under the rug. Next slide. So this is just another graph that I wanted to show about, adults who smoke who use specific illicit drugs. So here we have just a current illicit drug use in the past month. Adults who smoke, it would be 25.3, but adults who don't smoke, it would be 7.1. So it's almost a 20% difference. Marijuana, weed, adults who smoke as well as smoke marijuana, it's 21.8%, but adults who don't smoke cigarettes or any type of tobacco product and they smoke marijuana, it's 5.9. Adults smoke cocaine, it's about 2.5. And with adults who don't smoke, it's 0.3. So that's very low numbers. Heroin, adults who smoke cigarettes and also use heroin is 0.8%. And it actually shows, which is I thought was very interesting, adults who don't smoke and also use heroin, it's actually 0.0%. I don't know how accurate that is. There could be like at least a few pieces in there, but for the most part, it's 0.0%. Adults who smoke cigarettes and use any type of hallucinogens, it's 1.5. Adults who don't smoke cigarettes but use hallucinogens, it's 0.3%. Non-medical use of prescription drugs for adults who do smoke, it'd be 5.9. And adults who don't smoke but use non-medical use of prescription drugs, it's 1.5%. Individuals who in the past month have had current alcohol use and also smoked, it is 63.5, whereas adults who don't smoke, it's 52.8%. Binge drinking, 43.5% for adults who do smoke cigarettes and 21.7% for adults who don't smoke. And adults who smoke cigarettes and have very heavy drinking, it's 14.6. And adults who don't smoke, it's 4.5%. So we can tell from this graph, just because I realized how small it was, that's why I read it out to you. It's fairly a big difference. It's not so much in certain categories, but adults who smoke, there is a bigger correlation between them using any type of substance as well as smoking. Next slide, please, Sean. So the health effects. So people with behavioral health conditions die about 5 years earlier than those without these disorders. Many of those deaths are actually caused by smoking cigarettes. What we have learned in the past and what we should know is that there's a correlation between smoking cigarettes to every cancer in the body. So if you are someone who also has a behavioral health condition, you're more likely to die earlier and you'll have more of physical health problems. Additionally, individuals with a serious mental health disorder who smoke die almost 15 years earlier than individuals without disorders who do not smoke. The most common cause of death among people with behavioral health conditions are heart disease, cancer, and lung disease. And these are one of the major factors and what smoking can cause on an individual. Lung cancer, lung diseases, heart disease, these are all relatively associated with smoking cigarettes. And like I said, the most common causes of death among people with behavioral health conditions are heart disease, cancer, and lung disease. People with behavioral health conditions who smoke cigarettes are 4 times more likely to die prematurely than those who do not smoke. Like I mentioned before, it's 15 years of someone of a difference. They die 15 years earlier than someone who does not smoke and doesn't have a behavioral health condition. Nicotine has mood altering effects that can temporarily mask the negative symptoms of mental health disorders. So, this puts people with such disorders at high risk for cigarette use and nicotine addiction. With most substances, the mood altering effect is only temporary. There is a lot. That's why there's so much of a dependence on the feeling of when you're being on a specific substance. That's why there's so much excessive use of it, because it's temporary. And that is not, it's still the same for cigarette use or any type of nicotine use. So, it puts people at a higher risk for, dependence and consecutive use. Tobacco smoke can interact with and inhibit the effectiveness of certain medications taken by patients with behavioral health conditions, so often resulting in need for higher medication doses to achieve the same therapeutic benefit. Um, that does happen with a lot of tobacco products. You can't use specific medications for it. So you're going to be put on if you are someone who does smoke, you're actually going to be put on a higher dosage and unfortunately take more of a dependence on it. Um, so again, that's also one of the effects and health effects, but there are many health effects as well. With just in general having behavioral health condition, it's a big mental health effect that a lot of people actually don't really acknowledge. I know, especially this year, we've become a little bit more aware with mental health, but unfortunately, we are still kind of in the past few years, we're kind of in this stage where like, oh, you're just sad and then it's going to go away. It like comes in waves. We kind of always see mental health as one specific thing, but it's like a whole spectrum. We don't necessarily see a lot of the bad in mental health. And we do, it takes a toll not just on mental health, it takes health on physical health, financial, social health. So that's important to note as well, and that people don't see it as that. Next slide, please. Secondhand smoke. This is also something that's actually very overlooked. Secondhand smoke exposure. Only about half of mental health and 1/3 of substance use disorder treatment facilities report actually having smoke-free campuses. So, like I mentioned before, like we know from statistics, not everyone smokes, but you could definitely have the effects of a smoker. If you were near someone or in the same vicinity, you're still breathing in the toxins from the cigarette use, regardless or not if you are the one who is actually smoking. And secondhand smoke is the smoke from any type of burning tobacco. So that could include cigarettes, cigars, or pipes. And it has to be inhaled, and breathed out by the person smoking, and therefore you breathing in that air as well. And it contains tobacco smoke in general just contains about 7,000 chemicals, including the hundreds that are toxic and the 70 that actually cause cancer. But it does have a very higher, you have a very good chance of having any type of cancers or health conditions when you are a secondhand smoker. If you're living with someone who smokes and they do smoke constantly in the house, or if you are working with someone who smokes, it definitely has an effect on you. That's also something important to note as well. Next slide, please. Which one is that? No. Oh, which one is it? Big Tobacco's target on. Did we miss one? Quitting behaviors? Yes. Okay. Awesome. Thank you. So quitting behaviors. Many individuals with behavioral health conditions want to quit smoking, but may face extra challenges in successfully quitting and thus may benefit from extra help. it is, like I mentioned before, it is very hard, nicotine dependence. And I might also go into this more with the next slides. Again, there is a lot of stigma regarding people who want to quit smoking and have behavioral health conditions. Um, they might not receive the same care that they actually need when they do try to quit. So a lot of them are kind of shy away from actually quitting. People with mental health disorders are actually more likely to live in and have stressful living conditions. They're more likely to have low annual household income and lack of access to health insurance, healthcare, and help in quitting. Like I mentioned before, all these factors make it extremely difficult to quit. Fewer than half of mental health and substance use disorder facilities in the United States offer evidence based tobacco cessation treatments. They do have clearly mental health uh, treatments, they have substance use cessation treatments, but they don't actually have tobacco use cessation treatments, which is very interesting to note. Next slide, please. Okay, so big tobacco's target on individuals who use substances. Um, Big tobacco definitely targets a lot of marginalized communities. We've noticed that in the past several webinars, we noticed it with the LGBTQ community, where they would send brands of cigarettes to bars and nightclubs. They would also target low income housing, specifically Black and Latino communities. They would send them, be able to have people buy them on food stamps and send free ones out in low income housing areas so they can have customers. It's all strategic for them to particularly get that market. And, they have used, it's exactly the same for behavioral health conditions. So, developing relationships with and making financial contributions to organizations that work with persons with mental health disorders. So they do donate a lot of money to specific organizations. I do know tobacco companies, especially with the AIDS and HIV epidemic in the early 80s and 90s, they started actually donating to a lot of organizations and research and support. And they still do the same with mental health disorders and so on. So it's still the same tricks that they have. They would help fund research to foster the myth that cessation would be too stressful because persons with mental health disorders use nicotine to alleviate negative moods. So they help self medicate. Which we actually know doesn't really work. We do know that cigarette use does have a big factor in people relapsing from substance use. Um, they would provide free or reduced cost cigarettes to psychiatric facilities. They would support efforts to block smoke free psychiatric hospital policies. Because again, a lot of individuals who are going through these programs are smokers. And they would, like I mentioned before, they would target specific marginalized communities and marginalized populations. One particular, when I talked about HIV organizations they would donate to, they would also donate to other LGBTQ organizations, and they would call it Project Scum, which is a terrible name, subculture urban marketing, which is even worse. And they would, include, send a bunch of products, and they would donate a lot of money. So they definitely had a good target, and they clearly succeeded in a lot of what they did in what would be considered allyship, but in reality, they just wanted customers. Next slide, please. Okay, so addressing the stigma. There are many effective tools for individuals to have access to, especially if they want to quit smoking and also, quit their habits of substance use. But, many people don't really seek it out because, a lot of these resources are based on the stigma substance use has. Stigma is a problem with a lot of health conditions. They range from cancer to HIV and to many other mental illnesses that I mentioned before. Obviously, there have been some gains being made in reducing stigma around certain conditions, such as like public education. There's widespread use of effective medications that have demystified depression, like for instance, making it somewhat less taboo than it has been in past generations. But as I mentioned before, people don't necessarily see all sides of mental health disorders anymore or any type of substance use disorder. They really only see what has been portrayed inaccurately, especially on media and social media platforms. So that's something to note out. It's very little progress has actually been made in removing the stigma around substance use disorders. There's a lot of, stigma regarding people who have substance use disorders going to the hospital with healthcare providers. Um, they are denied access to treatment in fear of from the healthcare workers that they're only there to get specific medications, or even if they're an individual who's homeless and also has substance use disorder, they are also people are in fear of giving them money in order that they believe that they're going to buy drugs with it. It doesn't necessarily work out like that all the time. People with this actual addiction actually continue to be blamed for their disease. And we've noticed, especially in research, that that is not the case. A lot of people are products of their own environment. It's a coping mechanism. And people sometimes need to do what they can to survive. We've reached that consensus that addiction is a very complex brain disorder with behavioral components, but even people still see it as, a flaw of people's character, and they continue to view it as kind of like a moral weakness. So it's very crucial for individuals to really be educated on it, and especially people who are across healthcare fields, from staff in emergency departments to physicians, nurses, and physician's assistants. They should be trained in caring compassionately and competently for people with substance use disorders, and treating them with dignity and compassion. And this is the first step. I did also notice, especially with COVID, there has been a lot of, I wouldn't say backlash, but especially with EMTs or medics or people who are trained in naloxone or Narcan, they're less likely to use it because of the mouth to mouth component, um, or being such in close proximity to someone um, who has accidentally overdosed. So that's also something to note as well, that environmental factors also affect a lot of individuals, specifically people who have substance use disorders. So important to note. But like I said, addressing stigma, and really order for people to get the help they need. People do need to be educated on what substance use disorders are, mental health disorders, and any type of behavioral health condition. And that's one of the first steps, and to treat people with compassion and kind of work towards that goal. Next slide, please. So there are actually a number of strategies that we could help individuals quit. Like I mentioned, addressing stigma so people can get the access that they need, and access to all the treatments and resources that they need. So one is a number of policy strategies can be used in mental health and substance use disorder treatment facilities to actually encourage smoking cessation. There should be webinars, a little more pamphlets, and um, access to all that education and knowledge, so individuals can have the information at their fingertips, or in the facility to actually help them educate themselves. Tobacco-free campus policies that actually prohibit all forms of tobacco product use can support tobacco cessation. They can reinforce the tobacco-free norms and eliminate exposure to secondhand tobacco product emissions. That secondhand smoking is really, it does do a lot more damage than we fully realize. Counselors can ask clients who smoke cigarettes or use other tobacco products about their interest in quitting while in treatment for substance use disorders. And it should be less taboo of, you know, these individuals or these facilities to talk about tobacco cessation while they're going through treatment. They could still quit while they're in these facilities. They don't necessarily have to wait unless they want to. Evidence-based tobacco cessation treatment can help patients succeed in quitting, including cessation counseling and FDA-approved medications. Individuals' behavioral health conditions may need more intensive or longer-term treatment and support. And not just the clients as well, staff should be prohibited from smoking with and provided cigarettes to patients as an incentive or a reward. It's kind of counterintuitive if staff members are on the campus or in the facility smoking while others are trying to quit. especially these clients and patients who have a lot more development to quit not only just smoking cigarettes, but also kind of like nip their substance use in the bud. So should be kind of prohibited and should not be giving clients the incentives of cigarettes. Next slide, please. So the best defense to really quit smoking in general is to not start. Cigarettes are addictive, and avoiding the temptation to start is actually well worth it. Encourage your family and friends not to start as well. And, like I mentioned, everything really is about education and the knowledge that you have. If you have accessibility to all these resources about tobacco cessation, you should be able to freely give it out to other people, look into it yourself, and try not to start individually. If you are someone who is smoking, the best defense is to quit. It does take the average smoker 5 to 7 tries for actually stopping successfully. So don't give up. It's not like you only get one shot at it and you can mess it up. Quitting, it's never too late to quit. There is always free help available. There are always many options. If there was one way that wasn't right for you, there's always going to be another way. So you can keep trying. Ask your healthcare provider for help or call us individually as well. We have a lot of tips and resources that we can give you a better chance of quitting for good. Protect yourself. Secondhand smoke, like I mentioned before, is toxic. So don't tolerate, speak up, and advocate for smoke-free bars, restaurants, clubs, workplaces, mental health facilities, even parks and outside. Outside air really does travel fast. So be sure you are advocating and speaking up about it as well. Next slide. So one of the things, like I mentioned, it's never too late to quit. A lot of people kind of see tobacco smoke as like a done and deal. Once you've had smoking for years and years, the damage is already done to your body. That is not actually true. There's a very noticeable difference when you smoke. So this chart, when I say, if you stop smoking, you can even notice a difference after 20 minutes. Your heart rate and blood pressure actually drop. After you stop smoking, about 12 hours after, the carbon monoxide level in your blood drops to normal. 2 weeks to 3 months, your circulation improves and your lung function increases. Like I mentioned before, big issue on the lungs. But after 2 weeks to 3 months, your lung function really does improve. After you stop smoking 1 to 9 months, coughing and shortness of breath decrease. The tiny hair-like structures that move mucus out of the lungs, which are called the cilia, they actually start to regain their normal function in your lungs. So it increases your ability to actually handle your mucus, clean your lungs, and reduce the risk of infection. 1 year after you stop smoking, the excess risk of coronary heart disease is half that of a continuous smoker. So that's after 1 year. After you stop smoking after 5 years, risk of cancer around the mouth, the throat, the esophagus, and bladder are now cut in half. Cervical cancer actually the risk of that actually falls to that of a non-smoker. And your stroke risk can fall to that of a non-smoker after 2 to 5 years. After you stop smoking after 10 years, your risk of dying from lung cancer is about half that of someone who's still smoking. And your risk of cancer of the larynx, the voice box, and your pancreas decrease. And about 15 years after you stop smoking, your risk of coronary heart disease is equal to that of a non-smoker. So there are still a lot that you could do when you quit smoking. Your body's always developing and changing. So, if you do stop smoking now, there are still a lot of healthy benefits to that, with your body. It's not like a one-done deal. Next slide, please. I want to put a few ways to quit smoking. There is nicotine replacement therapies that you could try out. Like I mentioned before, there's no set way to quit. Everyone's very different. One person, could do well with the nicotine gum and you try it and it turns out absolutely terrible for you. Or even with the nicotine patches. It is a trial and error. Like I mentioned before, it's an average 5 to 7 times to quit. You just got to find what works out best for you. One important thing is to avoid triggers. We kind of incorporate cigarette smoking or any type of tobacco use in our daily lives. So change up a bit of a routine, try to avoid specific areas that you would smoke, or, certain people, to really trigger that. So try to avoid that as well. All costs, shake up your routine. Delay your use of tobacco smoking. Like if you're going to smoke 5 times a day, uh, try to reach for 4 times a day in 1 week. Then the next week do 3, and then the next week do 2, which really help you out. Get physical. If you are try to take some walks, slow, fast, however you like. If you want to, hit the gym, start learning, exercise in that way. It might also be beneficial to you if you are trying to quit. You can practice relaxation techniques, which is wonderful, and it really helps calm down ourselves, especially when I mentioned cigarette smoking and tobacco use is seen as a coping mechanism. If you find another coping mechanism for you that's very beneficial, it could definitely help with quitting smoking a lot sooner. And call for reinforcements if you need any help, or, need to be on track of something. We do have a lot of resources as well. Next slide. So if you need help quitting in the New York area, we have these few lovely places that do offer, tobacco cessation work. The ACN Tobacco Cessation Services, which is New York Presbyterian Columbia. These appointments are available at multiple locations across the ambulatory care network. For specific locations and to schedule an appointment, call 1-866-463-2778. Smoke cessation classes available through New York Presbyterian include individual, group, behavioral counseling sessions. Call the number listed below for more information on services or to make an appointment. So I do have the New York City Gov website on here as well. Montefiore Health System Tobacco Cessation Program, which is in the Bronx. You can call 646-988-2859 to call for an appointment. New York City Health and Hospital, Gotham Health, Cumberland Behavioral Health Pavilion Smoking Cessation Program. Oof, that was a long one, but they do a lot of good work. They are in Brooklyn, 205-718. Oh, no, never mind. It's not 205. It's 718-260-7756. So you can call for an appointment. New York City Health and Hospital Elmhurst Smoking Cessation Program. So that is in Queens. It is 8-334-2550. And the Richmond University Medical Center Tobacco Cessation, which is in Staten Island, and they are 718-818-239. And they have free programs available throughout the year. So they're in the 5 boroughs. These specific locations are in the 5 boroughs. So if you were in the 5 boroughs, you can find anything. And as well as the New York City Gov website will have a wonderful list that may be closer to you. Next slide. And these are a few of websites so you could just find quickly. You need help quitting. The smoke-free one is actually great. They actually have programs to text you, and so on. There is a CDC Gov index, as well as the heart.org and tobaccocessation.org. Next slide. So, like I mentioned before, in the beginning when I introduced myself, I am part of the C.A.T.C.H program here at Argus Community Action to Combat HIV and Hepatitis C. We do offer a lot of resources, and for anything sexual health, mental health, tobacco cessation, and COVID-19. One particular member of our team, Christopher Olin, he's the behavioral health coordinator. He provides HIV, hepatitis C pre and post test counseling. There's a GPRA, Government Performance and Results Act. He connects clients to medical services pertaining to HIV and hepatitis C. He connects clients to substance use services, including smoking cessation. He connects clients to mental health services. He can connect clients to local food pantries, and he assists uninsured individuals to get access to medical insurance. So if you are someone who's looking for a resource man, Christopher is your guy, and this is his information on his slideshow. Next slide, please. So I want to thank you all for joining us today. Just a little bit again about our program. Like I said, I am a health educator for the C.A.T.C.H program. I do the tobacco cessation webinars at 2 p.m. on Tuesdays. My lovely coworker, Yamina, who is also a health educator for the C.A.T.C.H program, she does the Tobacco Cessation webinars on Tuesdays at 6. And and also our lovely Sean Belgraves, who is our um, technological coordinator, who helps us out with all these webinars and helps them get edit onto YouTube as fast as possible or any type of social media platform. He's our guy for that. So I just wanted to take a quick shout out to him. And thank you guys so much for joining me today and joining us today. If you have any questions, be sure to feel free to reach out to us at our Gmail. You can call us at 929-322-4106. You could look up our information on arguscommunity.org, and you can follow us on social media. This is our link tree for Argus Catch. We have a YouTube, we have a Instagram, we have a Facebook, we have a Twitter, we have all kinds of things. So if you want to reach out to us there as well, you are most welcome to do so. So thank you guys so much and have a lovely day and stay safe. Thank you.